talking about balloon valve fracturing on a new level.
And while we're getting the slides pulled up, I just want to announce that there's going to be a faculty and attendee reception at 9 p.m. in former Saints Restaurant on the first floor.
So I do appreciate the invitation. Oh, got it. My fault. So good. Mark, I'm glad you're here because I promised you some of these data last year at this meeting, so I can close the loop on this. Okay, so here are my disclosures. So a lot of you, I think, have heard some BVF talks, but the bottom line is that patients with smaller bioprosthetic valves who are undergoing valve and valve TAVR have higher mortality, and we think that this is related to patient prosthesis mismatch. And if you've seen some of the data, there's no question that if the goal is to optimize the hemodynamic results of valve and valve TAVR, then BVF does a good job at doing that. In this series, the baseline mean gradient is 40. After valve and valve TAVR, the mean gradient is still 19. And after BVF, the mean gradient is 8. And the EOA is 0.8 at baseline, 1.4 after valve and valve TAVR, and 2.1 after BVF. We know that most surgical valves can be fractured, but what I'm going to concentrate on here is that some valves cannot be fractured, but they can be remodeled or stretched. And this is the current paradigm. These valves here can be fractured. These valves can be remodeled or stretched, and we can't do anything with these bioprosthetic valves. So what are we talking about? Who knows about BVR? Good, some people. So for example, an older generation CE Paramount can be stretched, but not fractured. In this case, a 21 millimeter valve was treated with a 23 millimeter S3. After valve and valve TAVR, the mean gradient was still 41 millimeters of mercury. And so the valve was dilated with a 22 millimeter Atlas Gold balloon inflated to 22 atmospheres. You'll see the waist of the S3 go completely away. You'll see the valve foreshorten as you would expect it to when it's fully deployed. And following that high pressure inflation, the mean gradient was down to 17 millimeters of mercury. So the older generation CE valves or Paramount valves can be stretched in that way. Trifecta valves are a little bit different. Here's a case of a 21 millimeter trifecta valve. A valve and valve TAVR was performed with a 23 millimeter Evolute. And at baseline, the mean gradient was 64. The valve area was 0.7. After valve and valve TAVR, the mean gradient was still 29, and the AVA was 1.0. So we performed BVR with a 22 millimeter true balloon. We inflated to 10 atmospheres. And what we're doing in this case is we're just flaring the post of the trifecta to better expand the core valve. It's not quite as striking as a BVF image, but after BVR, the mean gradient was down to 13 and the AVA was 1.4. We did some bench testing in collaboration with Abbott, and they, of course, had portico valves handy, and so we implanted portico valves into small trifecta valves, and then we did bioprosthetic valve remodeling with true balloons. And if you look at the orange line, this is the tip-to-tip diameter of these posts. Okay, and as you inflate the balloon and increase the pressure, the tip-to-tip diameter increases. And this is just the benchtop gradient. These are pristine valves, but the gradient does decrease as you flare out these posts. I should point out here that the clinical cases we've done, like the case I just showed you, have been with supraannular core valves. Portico is, of course, an annular valve, and you can imagine that if you're going to do BVR with a trifecta valve and you're flaring the posts above the ring of the surgical valve, that the supraannular valve may be the better selection, and you may see more of a decrease in the gradient with a supraannular valve. So we talk a little bit about who should undergo BVF and BVR. Certainly patients with smaller sized surgical bioprostheses. A true ID of 21 millimeter or less in prior studies has been characterized as small or intermediate sized. If you have high residual gradients following valve and valve TAVR, then certainly BVF or BVR could be considered. Again, prior studies have defined severe PPM as a mean gradient of 20 after valve and valve TAVR, but our threshold is lower. And we can ask the question whether all patients undergoing valve and valve TAVR should be considered. I touched on this a little earlier, but by facilitating optimal THV expansion, we might improve leaflet function and THV durability regardless of surgical valve size or the residual gradient. And here's a couple of videos if you haven't seen them. So on the left is a sapien valve implanted in a kind of a artificial ring, and you can see that the leaflets pinwheel when they close, and when they open, they're scalloped. And if you do BVF, when the leaflets open, they're not scalloped, they're opening as they should, and when they close, they're not pinwheeling. And you can imagine that in the case on the left, this abnormal leaflet function could impact long-term durability. Here's a couple of underexpanded valves that didn't do so well, and the patients had to go back for surgery. We do separate debates just on this topic. Is it better to do BVF before or after valve and valve TAVR? So I won't go into all the details, but some want to do BVF first so that we don't do a high pressure inflation inside the transcatheter heart valve, but maybe you can get severe AI, maybe you can get hemodynamic compromise or embolization. If we do valve and valve TAVR first, we can assess the results before deciding whether to do BVF. The high pressure inflation ensures optimal expansion of the THV, which might be good. But we could have subacute or acute injury to the THV. We should never perform BVR before valve and valve TAVR, though, and the reason why is here's a trifecta valve. So this is the valve as you take it out of the packaging. This is the valve after you do BVR. These posts are flared and the leaflets are tethered. They're tethered wide open. Okay, so you will have severe AI if you try to do BVR prior to your valve and valve TAVR, and this is the side view of that trifecta valve. When should we not fracture or remodel? We need to know which valves can be fractured and remodeled and not try to do this on valves that are not amenable to it. We need to look at the coronary arteries and the STJ and the LVOT, and we need to just understand the anatomy and ensure that the anatomy can accommodate the balloon that's going to be used for the procedure. Consider coronary protection and basilica if needed. I'll just jump to the last one. We don't recommend this type of procedure on patients who have had root enlargements, root repairs, or root replacements. We're not sure, although this has been shown to be pretty safe clinically, we're not sure in these cases that it would be safe. So in summary, valve and valve TAVR in small surgical valves is associated with increased incidence of PPM and higher mortality. BVF and BVR result in lower residual valve gradients and larger valve EOA after valve and valve TAVR. We need more data regarding durability of results and long-term outcomes. I just want to point out that BVF data are now being collected in the TVT registry in the device table. If you don't know about that, we can chat about it. And Danny is collecting BVF data in the VIVID registry as well. And if you're not participating in the registry and you want to, you can email his team. So I appreciate the opportunity. What was the end of your statement?
What was the question? What were the MACE rates in your BVF series?
Yeah, it's pretty safe. So the thing everybody worries about is root rupture or annular rupture, and we haven't really seen that. And we think that there are two reasons. One is that the LVOT and the annulus are debrided of calcium at the time of the original surgery, and the second is that aortic valves are placed supraannular on top of the annulus rather than within the annulus and the LVOT. It's interesting, we just had a case this past week that we did not do BVF on because there was LVOT calcium. So I don't know if it wasn't debrided at the time of the original surgery or if it recurred, but we didn't do BVF in that case. There were a couple of strokes in that 66 patient series. We get stroke with TAVR, so we don't know if it's resulted of BVF itself. We did have one case where this was before we fully understood. We talked a little about the maximum balloon size with a core valve. Early on, I didn't know that, that we were limited in terms of the size of the balloon we could use, and we did injure acutely one core valve and had to place another valve. And we did actually have, similar to what you saw, Sachin, there was one ruptured papillary muscle, and the wire obviously wasn't in the right place when that balloon inflation was performed. So that patient also had a mitral clip. So those were the main complications.
Sorry, Adnan, actually just two questions. One is, would you consider doing BVF in all of your small surgical valve and valve TAVR cases, regardless of gradient? And the second question is, do you believe BVF or BVR techniques have been disruptive to valve choice in TAVR?
Okay, so great questions. So the first one is that we actually do perform BVF in almost all cases as long as the anatomy permits, and we're trying to just optimize that THV and the leaflet function. It's going to be a long time before we can really assess durability, right? We only have 1 and 3 year data now from valve and valve TAVR, which I think everybody acknowledges is not enough. Session, your patient was 63 years old. What are the 10-year data going to be when the leaflets don't work well? Are we being disruptive? I hope so. So what I would say I think what you're getting at is that some feel that a core valve with the supraannular leaflets provides superior hemodynamics during valve and valve TAVR. I believe that as well. Our data suggests that if you do BVF, that hemodynamic advantage goes away. So in our series of 66 patients, there was no difference in final mean gradient based on Edwards versus Medtronic valves.
Okay, Mika, quick question. Excellent presentation, and congrats to have this captured now by the TVT. I mean, that's a huge evolution. Can you comment, please, on balloon valve fracture for TMVR? Because we were talking about that before. I think this pinwheeling we see beautifully on CT, and it's so common. Can you elucidate? So
I'll just give you anecdotal evidence because we don't have, we don't have evidence like I showed you here. We've seen high gradients after. And you think, we talked about the larger EOAs. These are larger valves in the mitral position, but we're not putting core valves in. We're putting, obviously intraannular valves in, and those leaflets are pinwheeling and not opening properly. And so even with a larger valve, we're seeing higher gradients, and I think we need to collect cases and find out what's going on here in the mitral. I think there's a strong case to be made that we should be doing this in the mitral position as well.
Have there been any delayed fracturing? Have you delayed any?
Yeah, so we've only delayed 1 day. I can't remember the exact story, but there's some reason we didn't want to do it. We brought it the next day. But James Harvey, I'm not sure if he's at this meeting, has got a series of a few cases that that he had done, kind of before the BVF disruption, let's say. And so he's been bringing them back up to a year later and not having any real complications associated with that. We've worried that if the valve is in the body for a year, maybe those leaflets are going to be stiffer and maybe there's a higher risk of acute injury, but he hasn't seen that.